là cái người mà là đến Việt Nam trong cái hội nghị dự kiến của Quan đây vài lần trước một cái báo cáo online rồi. Xin chào anh Đông Quan, anh Quan không? Xin rất là cảm ơn anh này để quay trở lại để có cái báo cáo. Anh em đang rất đợi cái thông tin từ những cái báo cáo rất là hay của anh. Và xin mời anh. Ok, đi đi em.
Liền cho chủ Quan anh share có nói được hay không nha? Một chút. Anh có thấy được cái chưa vậy?
Có rồi đấy.
Ok rồi, được rồi. Chờ Quan một chút nha. Ok.
Thưa giáo sư Đông Quan, hiện tại là trên màn hình của em chưa nhìn được slide đâu ạ?
Dạ.
Trên màn
Cái
hình.
gì? Chưa vậy?
Thầy chưa share cái bài báo cáo, share cái presentation.
Ok, trả tiếp nha, cho Quan trở lại. Okay. Okay, let's see. How do I share this? Bây giờ chị thấy được chưa vậy?
Nó chưa.
Chưa, ok. Đợi một chút nha.
Trong lúc thầy chờ xe thì các bạn thấy là mình ngại không? Thầy mặc rất đẹp luôn mà lại áo cổ phục. Đâm ra mình thấy ngại quá. Giá mà mình biết trước mà thầy xin ngang mình cũng mặc áo dài.
Dạ để ổn định đầu.
Thấy thầy rất là quốc hồn, cũng thấy rất đẹp luôn.
Để chị chờ Quan một chút cho Quan thử Quan đổi lại cái máy này coi thế nào nha. Okay, let's see. Ok, chờ Quan một chút Quan sẽ làm lại cái này. Một lần nữa.
Quan cũng áp dụng cái này về này không?
So can you help me to see how we can share? I think at this moment I need to share with the team over there. So how do I share it?
So it's Zoom?
Yeah, it's in Zoom time.
No, Zoom is not Zoom.
Huh?
No, this is...
This is Zoom, right?
No, Telegram is...
Yeah, it's Zoom, see? But I share,
No, I think we need to... It's to share. No, it's me. It's not Zoom. But you
so actually I share.
share there.
Okay, where?
Message.
Okay.
Oh. Let's see. Yes. Oh, it's for...
So now,
You can miss...
this one?
Yes.
This one?
Yes.
Okay.
And then share.
I did share.
Now
Let's see. Okay, now do I share?
What do you want to share?
I want to share this one. See?
Just presentation?
Yeah.
Maybe that one is good. Yes.
Then share.
Yes. Can do. Yes.
Thưa thầy, hiện tại chúng em nhìn được màn hình rồi ạ?
Ok. Chị muốn được không? Ok. Ok, xin lỗi nha. Hoàng hơi cái điều trục trặc với kỹ thuật chút xíu ở trong vấn đề này. So, trước tiên thì Hoàng cũng xin rất cảm ơn trong chương trình học có giáo sư ngẫu nhiên hơn trong đó bác sĩ Nguyen và chị là bác sĩ Thám Sư Khánh Vân. Và cũng đồng thời rất cảm ơn giáo sư Phạm Ngọc Đông là Phó Chủ tịch của Hội Giảng khoa Việt Nam cùng bác sĩ Hồ Xuân Hải là hai người đã mời quan tham dự buổi hôm nay. Thì cái đề tài mà Quan được gửi là do nói là hôm nay Quan muốn discuss về những cái treatment của cái phim của màng đào, bột đào, nhưng mà Quan sẽ dùng cái local therapy. So Quan sẽ bắt đầu cái đó. Thì Quan sẽ nói là Quan sẽ thuyết trình bằng tiếng Anh, rồi sau đó thì Quan sẽ trả lời cái câu hỏi bằng tiếng Việt Nam. So the disclosure from this here today, our University of Stanford have received various research funding from various groups and I serve on the various type of advisory committee. Certainly today we would like to focus on the management of uveitis, but in particular the role of local therapy that include topical, regional, and intraocular. We would like to see whether or not we can apply this as a primary therapy with this local therapy, or we use it as supplemental therapy in conjunction with stem therapy. Certainly, across the world, we know that visual mobility can simply occur due to uveitis, and that means that the goal of treatment of uveitis is therefore to reduce the intraocular inflammation. We want to make sure that we get to the stage where there's very much zero inflammation in order to reduce the visual mobility and to also preserve the vision. The guideline that we did so far is that we want to make sure that we treat early, and we want to make sure that the dose of corticosteroid, the equivalent of prednisone, should be less than 10 milligrams a day to avoid any side effect. So therefore, we hope that with adjunctive therapy, we will be able to reduce the long-term need for steroid. The question is why local immunosuppression? The majority of clinical manifestation of uveitis thus far have been thought to be due to immune response, and therefore the pathogenesis of posterior uveitis also consists of intraocular inflammation and therefore involves structures such as capillaries and the retinal pigmentary epithelium, all of which are damaged during the process of inflammation. And thus we want to make sure that we can control at all levels, including locally. At the moment, if we were to ask in 2025 and up in 2026, what are the local corticosteroid options that we have? Certainly we have intravitreal injections. From that, we have just simple intravitreal injection of triamcinolone. Then certainly we have the dexamethasone insert in the form of Osidet, and that was based on the HURREN trial that was published 14 years ago, published that the HURREN trial that lead to the use of the Osidet. Subsequently, we have the surgical intravitreal implant, and this is the Retisert that contains fluocinolone, 0.59 milligram of it, and the study that led to it used. And then most recently, we have the intravitreal insert, whereas the Retisert we need to perform in the operating room. Injectable intravitreal insert, we can do that in the clinics in this aspect, and that's in the form of UT of that aspect. And then most recently, within the past 2 years, you have heard of hospital, we're now using suprachoroidal delivery, whereby we inject the steroid to the choroid first to get to the suprachoroidal space in this aspect. So the role that also, what about non-steroidal in this aspect? In that case, we have topical instead of non-steroidal inflammatory drugs, and then we also have intravitreal of non-steroidal anti-inflammatory drugs in this aspect. For what about local immunomodulatory therapy? In that we have topical cyclosporin, we also have intraocular methotrexate. We also have complement inhibitor that you may have seen so far. This is including the use of the LG, which is an NSC5 intravitreal delivery. This aspect, we also have intravitreal adalimumab, and we have intravitreal infliximab that is also available as a film intraocular, although further study are needed with this aspect from there. Let me take some time now to discuss about intravitreal methotrexate for non-infectious uveitis in this aspect. Certainly you have seen the literature, you've seen cases with this aspect. So intravitreal methotrexate was first introduced for the treatment of intraocular lymphoma. Intravitreal methotrexate appeared to be quite promising in terms of that aspect from there, and some cases have been shown to use in phakic steroid response due to the lower risk of intraocular pressure. Studies also show that intravitreal methotrexate alone may be adequate to achieve remission. Now, when I say studies here, these are a lot of case report and case series. So we obviously have to ask the question, are there enough phase 3 study to make sure that this treatment is appropriate with this aspect from there. So this table shows you various publications in the literature, case series of that type of thing, to show the potential ICP, broad intravitreal methotrexate with this aspect from there. Here they were used mostly in intermediate uveitis and cystoid macular edema of intravitreal methotrexate. Here's a case for this. This is a case of CME that respond to methotrexate, and you can see that they can do. But again, these are individual cases in there, so we always ask the question whether it's truly can use that function or not. In addition, the patient with intermediate uveitis and also with vitritis can also show a response to intravitreal methotrexate that has been shown some cases in there. And also, the other thing that the intravitreal methotrexate has been used, and it probably would be quite useful to know in the country like Vietnam, when it's used to treat paradoxical worsening. So this is when you have, for example, tuberculosis or ocular TB that involve the colon. We, of course, treat the ocular TB with anti-TB therapy, ATT. What happens is that we have learned, and has been also been published already, when you treat with ATT, what happens is that you can get worsening of the disease because of the inflammatory response in that aspect. So therefore, you need an anti-inflammatory treatment aggressively to avoid what we call paradoxical worsening, and this has already been published, and it's actually very important when we manage this type of thing. So therefore, that's another potential role for that aspect with intravitreal methotrexate. Now, if we ever use intravitreal methotrexate, you need to know the potential side effect for that, and the potential side effect to that include corneal toxicity, and this has been reported before. So what happens is that when you inject a lot into the vitreous, or even when you use a lot into the sulfate, you will get keratopathy of this aspect, and you will get deposition, you get damage to the endothelium as well. So that's when you have to be really worried about that concept. Let us move to the next drug. This is intravitreal adalimumab for non-infectious uveitis. Certainly, when you hear adalimumab, and later today you will hear Dr. Nguyen present his work on the use of adalimumab for pediatric uveitis. But here we want to, this is one of the biologic TNF inhibitor. And when adalimumab comes into factor is when the Visual 1 and Visual 2, two phase 3 study, which was done about a decade ago, that showed its effectiveness given at a systemic treatment to a subcutaneous injection lead to its use in treating patients with uveitis quite effectively. That's the Visual 1 and Visual 2 study. So when we publish the data, it's helped to make adalimumab the first biologic that's been approved for the treatment of uveitis worldwide in this aspect. So this is given systemically. Now we're talking about intravitreal adalimumab. So if you look at the literature, you will see several studies have done that. Sophia Trudy is one of our colleagues from Greece, and she published one of the first papers here. Here, Sophia Trudy and her team were looking at the dose of 0.5 milligram in 0.005 ml injection of that. And with that dose, they did not show much effectiveness in this aspect. However, subsequently, the groups from Lebanon published this paper where they tripled the dose to 1.5 milligram in this aspect. And in this pilot study, it did show the potential benefit of that aspect. So the question remains whether or not when you need to use intravitreal adalimumab, would that work? And this has to require careful preparation because you cannot just inject it into the eye without preparation like this. And if you get the right dose of it, it may be a helpful thing. So this is still a question whether or not this may work well for this aspect. But if it does require that you use a much higher concentration of it than before. What about infliximab? So we just talked about adalimumab, a tumor necrosis factor inhibitor. Now we move over to infliximab, which is also another TNF inhibitor. But infliximab, instead of being injected sub-Q like with adalimumab, is given as intravenous. Typically, can we take infliximab and inject into the eye? Well, it has been tried before because people consider that to be local therapy. The problem is that you can see it in some cases that it can show improvement. However, and this is the important fact, there's also been evidence to show that when you take intravitreal, when you take infliximab and you inject it into the vitreous, you can cause toxicity to the retina, with complete suppression of response in the ERG. So we therefore do not advocate for this unless we have to do additional study when we proceed with this aspect from there. Now, those are some of the local agents that we have discussed potentially used locally into treatment beyond corticosteroid. Let's talk about a little bit about macular edema. Certainly, macular edema, most common cause of vision loss in patients with uveitis, can occur in about 40% of patients with non-infectious posterior and uveitis, that aspect from there. It is very important to recognize that uveitic macular edema can persist in the eye even when the inflammation appears to be controlled. Another word, macular edema, uveitic macular edema can occur when the eye has no vitreous cell or no inflammation of the optic nerve of the vessel in this aspect. In one of the studies that we will discuss very shortly, the MUST trial, 62% of the eye treated systemically need regional injection for the treatment of cystoid macular edema. This is one of the complications for this aspect from there. What about the visual impact of this? This is certainly a very important. This is a series that's coming out and this paper of 175 patients of macular edema among the very large group of patients in there. And we have learned throughout the year that increases of uveitic macular edema have to do when patients have increased age, chronic inflammation, and specific entity, for example, birdshot or sarcoidosis. This is a condition that we have known throughout the year that can lead to the occurrence of uveitic macular edema. And it is one of the leading causes of visual blindness in eye with uveitis, so it's very important with this aspect. The risk factor for uveitic macular edema, in summary, are to follow: male, older patient with chronic uveitis, which is a very, very important factor, and the patient with posterior and uveitis as well from that. And also patients have vascular disease in that, and then certain drugs, and this is important to recognize that few drugs can also be to cause that. For example, one of the well-known drugs called fingolimod, which is a drug that used to treat multiple sclerosis, fingolimod, MS drug, that have a very well-known risk of causing macular edema. And then other things that we see in tamoxifen is another one of this aspect that can do so. Now, you will see in the literature, there's a study called MUST, M-U-S-T, and that stands for multi-center uveitis steroid trial. This is one of the first trials that we're looking at systemic therapy versus local therapy to control uveitis, and it occurred over a 7-year period of time. The upper outcome, when we look at systemic therapy versus local therapy, the upper outcomes seem to be comparable, and perhaps even favor systemic therapy. However, in that study, the local therapy would not equal. In other words, they only received very initial therapy with local therapy and did not stay for long. However, we did learn that from local therapy, instead with steroid, does increase the risk of glaucoma and cataract, and overall with that aspect. So if you were to look at this table, would come out from the primary paper that look at the implant in gold and systemic therapy in the light blue, you will see that over a period of time, the way it can control, so they seem to be similar with two groups. And this is when you compare between systemic therapy, when the patient has to take systemic drug, and then when they compare to local therapy, you're able to be told that you can get full control of this aspect from the field. The 7-year result of controlled uveitis and macular edema, if you notice in this graph on your left-hand side, the gold curve is implant. As you can see, it leads to control a lot faster with local therapy. But by the 5, 6, 7 years, the systemic therapy will catch up. However, there's a potential problem here. That is, those with local therapy did not get the second implant. And in this case, the local therapy was the Revisor, the one that contained the fluocinolone that lasts for about 2.5 to 3 years. However, over the 7 years period, most patients in that trial received less than 2 implants. So that being due to the way that they're probably likely undertreated. But the one impressive with the local therapy, if you look at the graph on the left-hand side, is that the golden curve, the improvement occur a lot faster in this aspect. Another study that you should be aware of is the study that asks this question: when you need to give, let's say, steroid in the eye, which way is the best route? Is it a periocular? Is it an individual? Or is it like an in-and-out? So this is called a PHImôN study, which also been published already. And as you can see from this graph over here, the individual steroid or the dexamethasone appear to be quite well, but the periocular route does not appear to be well at the other two. So if you're going to try to give steroid to control inflammation, it is best to give inside the eye. Granted that you need to be aware of the other complications that can occur with this aspect from there. This is another aspect of the PHImôN study in here, and that is the cases that they see the resolution of the thickness of any edema, and also when you see that aspect from the intraocular pressure, it seems to be similar as well. So what we learned from this PHImôN study is that if you need to give steroid, it is best to give it intraocularly rather than the periocularly on this aspect from there. Another study that you would like to know about is called the MERIT study. Now, as you can see, I start the talk with giving you some of the case reports, some descriptions, let's say the use of methotrexate, local therapy of that aspect. And I say that those were case report, case theory. In general, when we talk about any result, we have to consider a multi-center and also a randomized control trial to really understand. So that's why the MERIT study was designed. And this study looked at 3 different routes and 2 different medications. Individual methotrexate, which is what we just talked about. Individual ranibizumab, which is a VEGF antagonist, vascular endothelial growth factor. And the third one is individual dexamethasone. So each of these 3 agents has been shown to be working well in controlling macular edema. So the best way to compare them to see what the best is actually put in a trial, and that's what we always do in ophthalmology to prove a point. So we compared all 3 of them, and this is what we learned. There was significant improvement with visual acuity and sensitivity in patients receiving intravitreal dexamethasone. The methotrexate, even though there's some cases that show some benefit, into a macular edema, it was ineffective. So this is an example to show to you the power of clinical trial. When you want to ask a question, you need to conduct trial. You cannot just rely on case report of this aspect from there. And so we recognize it's not always possible to do clinical trial, but whenever possible, one needs to perform of that nature. Ranibizumab is the agent that shows slight improvement but not completely effective with this aspect as an intervention agent here. So the MERIT study is the one that looked at the 3 different diagnoses of that. This is a table coming out from Dr. J.P. Dunn from the Will Aspen Hospital in Philadelphia that shows sort of like an algorithm in which how you would treat macular edema from anterior intermediate uveitis or posterior uveitis, and you go down the path, the tree end there, to see where we can go and where we can stop. Obviously, there's variation in between, but that's what we like to do in this aspect. So when we talk about uveitic macular edema, we want to look at conditions that can potentially lead to that between infectious and non-infectious. And the two of the infectious, you will see here, all of this toxoplasmosis and tuberculosis, as well as sarcoids and adamantitis Behçet, all of this can cause macular edema. Certainly, in this aspect from here, you have sarcoidosis and bullshot, which is a condition that occurs mainly in the West, that we also see potential macular edema as well. So these are things that you should be aware of that can cause macular edema. And then, certainly when you discuss about the classification of uveitis to see which one associated with the macular edema, you break it down into this, according to the some classification, anterior, intermediate, or posterior aspect from there. So far, I've shared with you some of what we knew, some of what we are using, that so far. Now I'm going to share with you some of the local therapy that in development for non-infectious uveitis, because this is important to know what's coming on the horizon here. The first thing I'm going to do is to a compound called OCS01. This is a new compound that we've been looking at to treat uveitic macular edema in the LEOPARD study. So what does this actually do? This is, as we mentioned, uveitic macular edema is a very common complication of uveitis, and we want to make sure we can control it with this aspect. So the incident of another possibility is the post-surgical macular edema. This has happened when you do, let's say, cataract surgery or vitrectomy that have macular edema. So this is the incident that can occur in this aspect from there. So two conditions, uveitic macular edema and post-surgical macular edema, this aspect. And both of them are unmet need because we don't have a very strong treatment for them. So the unmet need here is the residual need for the treatment of uveitic and post-surgical macular edema. This so that topical dexamethasone cyclodextrin. So one of the studies that have been in the past that shows some cases that respond to this thing. This is a unique molecule, OCS01. This is a topical dexamethasone cyclodextrin. So it's not just a regular dexamethasone, but the dexamethasone that wrapped around in a carrier called cyclodextrin, which is aspect from there. So what it is this is a unique formula called optimized formulation of dexamethasone. In this aspect, cyclodextrin or hydrophilic carrier. So you take a regular drug that you know, like dexamethasone, you wrap that and you put it inside this water-soluble complex, and now you have an excellent topical concentration and a solution to deliver to the eye to help with that. So you may have seen already that this compound, OCS01, have already shown effectiveness in trial with diabetic macular edema. That is the Diamond study, phase 3 double mask. And when you compare the vehicle alone, it shows significant benefit from that. It's actually the first topical drug that showed that it can help to reduce macular edema in diabetes. So using with that, we have learned that it's very important to do with this aspect. And for example, it can lead with just a few months of topical delivery of OCS01, you can gain visual acuity with that without any injection of that. So that's very positive news. So based on this positive news, we designed the leopard study, which is the one to evaluate the effects of OCS01 on visual acuity and central subfield thickness in patients with uveitic macular edema and post-surgical macular edema, which is aspect from there. We look at the central subfield thickness, and we look at also the change in visual acuity, which is aspect. So this is a study that Stanford leads among the number of centers, like 8 other centers here, you can see here, and we are about to finish enrollment of this study. We're looking forward to share the results because this is a very powerful agent of this aspect. And because of the fact that it's wrapped around cyclodextrin, it doesn't get much block, it doesn't go to the regular measure because and therefore it doesn't seem to increase atrial blood pressure much. Next one we want to share with you is local interleukin-6 inhibitor. So you should also need to know this because this can be very helpful for you to know this for both retina and uveitis. And one of the molecules is amibacor. So where does this concept of interleukin-6 come from? This is when about 8 years ago, we published one of the first major studies in this field that showed that interleukin-6 in the form of tocilizumab can be quite effectiveness in patients with non-infectious uveitis, which is aspect from there. And this is still at the private so, but in the past, we used tocilizumab, and now in the clinic as well to be used as intravenous delivery of it there. So this aspect from there. Now, what we want to look at is, can we deliver anti-IL-6 as an intravitreal injection? So yes, the molecule is called amibacor, RG6179. This is a fully humanized IgG2 monoclonal antibody that engineered for intravitreal delivery in patients with ocular disease with this. So certainly one of the arguments why we need this is to make sure that we can reduce systemic exposure and we can have fast systemic clearance with this aspect from there and this aspect. So the intravitreal amibacor was on 2 major phase 3 international studies called MEERKAT and SANDCAT, and the result was just published, the result was just presented at the American Academy of Ophthalmology meeting about a few weeks ago in Orlando. In this aspect, in that it does show some benefit when you use intravitreal interleukin-6 delivery. That's the The question we want to find out is that this would be whether they are effective as systemic control. That's in there, but certainly that's a possibility. Another molecule that you should be familiar with and want to show you something next story. This is called KSI-501 and KSI-101. So these are novel bispecific antibody that have both an interleukin-6 arm and an VEGF arm. So in the same molecule, you can block both interleukin-6 as well as VEGF in this aspect. So this is the dual inhibition of VEGF and interleukin-6 to compare superior normalization compared to either anti-VEGF alone or anti-IL-6 alone. So certainly that is the hypothesis that we hope to see it will block both. And currently, so both of these are currently in clinical trial right now. So hopefully in the near future, we will share with you some of the results with this aspect. But here you have a dual inhibition of both of these groups from there, and we are involved with this program as well. The third study that I want to discuss is on a new molecule that you probably have not heard of before. This is one of the latest molecules that we're looking at. It's called laquinimod, and this is in a study called the LION study that we're conducting at the Bioinstitute at Stanford right now. So this is a molecule that is developed with a synthetic small molecule immunomodulator. It's a very new class of drug. It targets something called AHR, aryl hydrocarbon receptor, in the antigen presentation cell. So what it does in there is it blocks so that the antigen present cell will not be able to work. And because of that, you don't have much activation of inflammatory cell aspect. So this will go upstream of the inflammatory process from this aspect from there, and therefore you basically move the immune response to the anti-inflammatory phenotype. You can see from the scale on the left-hand side, whenever you have inflammation is when you have an imbalance of pro-inflammation versus the immune tolerance. So what we want to do, we want to go to the anti-inflammatory phenotype from this aspect from there, and that's what we want to do in this aspect. So this laquinimod has already been used as an oral form in a CNS disease with this, and phase 2, phase 3 study, oral form of laquinimod seems to be doing well in patients with MS, for example, with this aspect. And it seems to have very good outcome from there. It does have some potential side effects, for example, headache or nausea and the mild elevation of liver enzyme, again with this aspect from there. So because of that, and because we were asked the question whether or not we can develop a topical formula, we work with the team and we developed this topical anti-inflammatory of this aspect. We already saw topical corticosteroid, we used it, and we saw, for example, OCS01. We want, however, occasionally reduces some side effect of cataract and also that. We want to see whether or not that can be possible with that. So therefore, topical formulary of the laquinimod has been developed with this. Now, one of the questions we always ask is that if we apply something topically, would it be strong enough? Can it get into the vitreous of the eye to deliver into the posterior segment? So what we did was, we know from the preclinical study that you can get an eye drop, but the question is whether or not you can get enough to this aspect from there. So what we want to do is we want to see whether when topical laquinimod applied, can it get to the back of the eye? So that's why we designed the LION study, which is the one that looked at the safety tolerability of laquinimod in patients that can receive it and whether this can get enough into the eye in this aspect. This is a phase 1 study that we just finished conducting at Stanford with this aspect. So we want to include patients who are 18 or older who were scheduled already to undergo post-laminectomy and with the reasonable pressure. And what we do is that we apply the eye drop to it, and then we want to measure the concentration in various forms. So here in this study, we look at 2 different doses, 0.6, 1.2, and 1.8. We treat the patient for about 2 weeks before that, and then subsequently we want to see what the concentration is. And interestingly enough, the result was quite promising with this, and that is when you look at the concentration in the undiluted aqueous humor as well as the vitreous, we see a very nice response. So in other words, the more you eye drop you put, the higher the concentration in the anterior chamber, but also you also see from that in the vitreous as well. So this is a very nice dose response curve with this aspect. So with this result, we are quite very encouraged that we can get this eye drop into the posterior segment to potentially treat with this aspect from there. And certainly we want to also ask the question, if you apply an eye drop like this, will it get into the plasma or not? And so far, we also noticed on that concentration of that. So with that, we feel very comfortable that this is a good potential topical drug that can be applied to hopefully into posterior segment disease as well from this aspect. So the safety so far with this, we did not have any problem with this topical delivery of the laquinimod, so we're very encouraged with that. What we learned so far is when you apply topical like this, you can get a laquinimod, you can get what we call a dose-dependent drug level, which can be very helpful. And this is what we see in the vitreous seem to be in most importantly in the therapeutic range and all the doses with this aspect from there. And this also can lead to potential benefit in treatment of that. So this is our summary slide here. The future of the uveitis therapy, you will hear me or any other colleague talking about this, is quite nice because we have a number of potential treatments that are coming down the pipeline. We're working very hard right now to look at different ones. I just share with you a portion of it in terms of patients that can be treated with topical and what are some of the topical treatment is. Certainly, whenever we treat any of this patient, the goal for any therapy would be to make sure there's no tolerance to any degree of inflammation, and that's what we want to do. So thank you for your attention with this aspect from there. We are very, very pleased to have been able to contribute to the educational purpose of the Vietnamese Ophthalmological Society. This is our team at the Bioscience at Stanford. We welcome our colleagues to visit and to join us in a different way. And with that, I thank you for your attention.
Ok, cảm ơn bài báo cáo của bác sĩ Nguyễn Quan Đông Quan. Là một cái bài báo cáo rất là hay và rất nhiều cái thông tin về cái điều trị một cái bệnh mà tất cả mọi người đều là cả thế giới là đều kêu là rất khó khăn. Viêm màng bồ đào là năm ngoái mình có cái hội nghị về cái viêm màng bồ đào, anh giáo sư Dung Quang cũng đã đến là trình bày rất nhiều cái thông tin rất mới. Thì tôi đề nghị là chúng ta có cái câu hỏi, có trao đổi gì thì cho kiếm được trao đổi hay để Quan có thể trả lời. Tôi xin mời anh. Okay.
Thank you very much. I'd like to know what is your approach for intermediate uveitis, especially when we cannot find out any cause of it.
Okay, so first, thank you for the question. I would like to find out if I speak in Vietnamese, can you understand, or do you have a translator for you?
Oh, I don't have. So, yeah.
Fine. So I'll speak in English so that you can hear, but certainly I can do so in Vietnamese as well. So the approach for intermediate uveitis is that you would like to find out where the inflammation is and depend on whether or not it's a unilateral or bilateral, and whether or not there's macular edema involved. Intermediate uveitis is defined as inflammation in the postplanar areas where you see inflammation there. You also see inflammation that can occur. It will depend if indeed you see the optic nerve involved and you also see the macular edema involved, then you want to be as aggressive as possible over there, because you know that if you let the macular edema there persist for a long time, for example, you can lead to irreversible visual loss. So this is important. So our philosophy is that we tolerate no inflammation. So we also always want to make sure we control the inflammation to the maximum level with this aspect.
Okay,
and that includes a combination of both systemic and local therapy. So I am not shy at all in using systemic therapy to control it, because our goal is we do whatever we can to eliminate all inflammation.
Thank you. And one more question about implants of dexamethasone. How often do you use it? Because it says around 6 months, but sometimes we can see just less than 4 months. So when it degrades, you use next one, or you wait until 5 to 6 months?
Intravitreal dexamethasone, that's the Osidex that is available in Vietnam right now. So this is very familiar with many of our colleagues there. So intravitreal dexamethasone in the study called the HUON, that was the study that led to the approval of dexamethasone implant for uveitis. That one indicated it can last up to 6 months. However, in clinical practice, we know that it does not last that long, usually about 3 to 4 months. So what we do is that we do not wait until we see complete sort of like disappearance of the Osidex. Rather, we want to see whether we see any recurrence of the disease. So let's just say you use it to treat macular edema. As soon as macular edema returns, you know you now need to treat again. You don't just wait around for that.
Thank you very much.
Mời mọi người có câu hỏi. Tôi muốn trao đổi như vậy là cái viêm màng bồ đào mà không nhiễm trùng ấy, là một trong những cái bệnh rất phức tạp, và nó một trong những lý do để điều trị rất khó khăn là nó hay tái phát. Tuy nhiên thì những cái thuốc mà mình nêu ra là những thuốc rất tốt, nhưng mà có điều là nếu mà ngay cái viêm màng đào mà không biết dùng ban đầu mình dùng những cái thuốc ấy ngay thì tôi sợ là nó hơi khó. Đấy là những cái điều trị thông thường, điều trị tại chỗ thông thường bằng các cái corticoid mình tra tại chỗ, và thường đa số những cái viêm màng đào thì là nó thoái lui, còn chỉ một số ít thôi là phải dùng đến những cái thuốc mà như đây giới thiệu. Thì theo anh như thế có nên không, hay là ngay từ đầu mình dùng những cái thuốc mà anh giới thiệu đây?
Cảm ơn chú Sư Hưng đã hỏi cái câu hỏi này. Thì trong cái sự hiểu biết của trong cái môn này đó thì mình có thể đồng ý là ngay lúc bắt đầu mình cũng nên dùng corticosteroid, nhưng mà nó có rất nhiều những căn bệnh chẳng hạn như VKH, chẳng hạn như PHIêN, mình biết là mình không thể nào mình dùng corticosteroid để mình trị cái này hết. Khi Quan nói không có dùng corticosteroid được là mình không thể nào mình dùng mà ở cái low dose, tại vì trong những cái bài quảng cáo đó thì là nếu chúng ta phải dùng corticosteroid nhiều hơn là 7.5 mg mỗi ngày thì chúng ta không thành công rồi. Dĩ nhiên mình có thể mình dùng 40 mg hoặc 50 mg thì có thể nó được, nhưng mà chuyện đó thì nó có rất là nhiều sự nguy hiểm cho người bệnh nhân. Do đó có những cái bệnh chẳng hạn như ví dụ mình gặp cái bệnh VKH, VOS2025 thì mình biết là mình có thể mình dùng corticosteroid mình trị, nhưng mà mình cũng biết trong những cái bài diễn biến là mình dùng nó trong một thời gian thì sau khi mình bắt đầu mình thấp xuống cái độ của corticosteroid thì là cái bệnh nó sẽ trở lại, thành ra mình không thể nào mình bắt đầu đi được. Thành ra ngay từ lúc đầu thì là mình dùng như anh nói là mình dùng cái cũng như mình dùng corticosteroid, nhưng mà mình biết là trong vòng 1-2 tháng mình phải check cái corticosteroid out. Thành ra mình phải hỏi là cái người bệnh này trong vòng những cái năm tới họ sẽ dùng những cái gì để có thể trị được. Thì mình không muốn dùng corticosteroid tại vì có nhiều side effect quá, do đó mình phải dùng những cái tiếng Anh gọi là steroid sparing, như anh nói đó, tức là mình không có cần phải dùng cái corticosteroid nữa mà mình dùng những cái thuốc khác, nó vẫn có thể nó giữ được cho cái viêm nó không có tái phát. Thì hoàn toàn như nói là đúng lúc đầu khi chúng ta mới có thể dùng thì mình dùng những cái corticosteroid, nhưng mà phải suy nghĩ nếu trong 2 tháng nữa mà mình không còn corticosteroid nữa đó thì cái người bệnh nhân cái viêm của họ có còn nữa hay không. Nếu mà chúng ta sẽ thấy còn mà chúng ta phải trở lại để dùng corticosteroid thì cái đó chúng ta bắt buộc chúng ta phải đổi qua một thứ khác.
Thực ra là ở đây là thầy giảng là có một cái rất là hay và rất là chuẩn để mọi người hỏi cái thuốc cuối cùng mà thầy nêu cái 521, cái thuốc điều hòa trước kia thì chúng ta nói cái thuốc thực ra mình biết cái thuốc này hầu như là dùng toàn thân, bây giờ dùng đấy là cái gốc đầu để dùng cho cái sơ túi mạch và điều trị hại não, để mình được đưa và bây giờ bắt đầu đưa sang nghiên cứu cái PHImôs ở trong cái viêm màng đào này, và cái rất là hay. Mỗi tội là chắc là giá cả thì nó cũng sẽ tương đối là đắt, nếu không hiểu thầy có thể cho biết cái giá mà ở Mỹ bây giờ nếu đang dùng thì nó là bao nhiêu không, hay là cái này vẫn là PHImôs thì nó là vẫn là đang được off label và vẫn đang được tài trợ.
Dạ, cảm ơn chị bác sĩ Khánh Linh đã hỏi, thì chị hỏi rất là hay câu hỏi này đó. Thì cái quá trình học của anh trong vòng 25 năm vừa qua đó, thì Quan chú trọng là làm cách nào mình có thể mình tìm những cái thuốc mới mình đem tới cho bệnh nhân, và nhất là không có sự nguy hiểm đó, thì mình đi tìm những cái thuốc nào mà mình thấy nó có một cái khả năng có thể nó trị, rồi mình nhìn coi có thể nào mình đổi nó từ viêm systemic, từ cái nguyên toàn thân trở về mắt hay không. Thì do đó mình mới nói đây là như chị nói đó, cái là PHImôs này là một trong những cái mà nó đã có sự thành công ở bên ngoài rồi. Thì mình trong những cái bệnh như là MS hoặc là lupus nó cũng đã có rồi. Rồi Quan mới nói chuyện với tụi nó, rồi Quan mới nói là bây giờ đó, tôi muốn đổi cái này thành một cái thuốc nhỏ được không? Tại vì vậy thì là một là nó sẽ rẻ hơn, tại vì nếu mình dùng mà cho như chị nói là mình dùng cho toàn thân thì thường nó sẽ dựa theo cái người bệnh nhân nặng bao nhiêu thì nó sẽ mắc rất nhiều mình cho hoàn toàn thân. Còn nếu mình có thể mình dùng trên mắt thì nó sẽ rẻ hơn rất là nhiều. Thì là tụi này mới làm cái đó. Thì giá bây giờ tụi này không chưa phải tại vì nó chưa có đi tới cái mức độ mà nó ra tới ngoài thị trường, thì thành ra mình hiện giờ mình vẫn còn dùng cái trong cái khả năng để mình tìm hiểu. Nhưng mà cái mà mình thấy rất là có cũng như rất là có cái phấn khởi là mình thấy là khi mà mình nhỏ trong mắt đó, cái thuốc này nó đi tới ngoài sau. Thế là cái tránh là tại vì nhiều khi mình nhỏ nhưng nó không có đi vào cái uterus được, nó không có vào cái rectum được. Cái này thì nó có thể nó vào được, thì mình thấy vậy là một cái sự rất là phấn khởi. Và nhất là nó vào mà nó theo cái trình độ bao nhiêu nhỏ, tức là mình nhỏ ít thì nó sẽ vào ít, dần mình nhỏ nhiều thì nó sẽ dần nhiều. Như vậy nó gọi là dose response. Thì những cái thuốc mà có thể đó làm cho cái dose response nhiều thì nó rất là tốt so với cái thuốc khác đó. Thì Quan hy vọng là Quan tiếp tục những cái đội ở bên cái team ở bên Stanford đang cố gắng làm cái này để đem nó tới một cái gần bệnh nhân hơn đó.
Nói chung là một cái báo cáo tuyệt vời, anh với một lượng kiến thức và thông tin rất tốt, cũng như là một người có rất nhiều kinh nghiệm chỉ bày chúng ta rất là cảm ơn anh Đông Quan, và hy vọng là trong thời gian tới, sắp tới là chúng tôi có cái hội nghị dịch kính của Quan ở trong Cần Thơ và hội nghị nhãn khoa toàn quốc vào tháng 10 ở trong Nghệ An. Xin mời anh lại trở về Việt Nam, thăm Việt Nam và có những cái báo cáo để anh em tôi được học hỏi. Một lần nữa chúng tôi xin về cái cho một cái cảm ơn xin lỗi.
Dạ, chúng ta làm ạ.
Tiếp theo thì chúng ta sẽ có một cái